This presentation will be on an immunology-related case study. Before we get into the actual case, these first couple of slides will give some general information on immunologic and serologic testing. Some common tests used to assess immune disorders and diseases include C-reactive protein, erythrocyte sedimentation rate, antinuclear antibodies, immunoglobulin blood test to determine type, and immunoassays to determine concentration. The methodologies of these tests can include precipitation, particle agglutination, electrophoresis or chromatography, immunoassays that may use labels, flow cytometry, and molecular methods. The specimen used in immunologic and serologic tests will usually be serum, although other fluids may be used, such as urine, for HCG testing. If the specimen shows lipemia, hemolysis, or bacterial contamination, it should be rejected. You should also avoid contamination with alkali or acids because they have a denaturing effect on the serum proteins. If the specimen is icteric or turbid, it may still be okay to use. You could still get valid results for some tests, but it may interfere with others. As for collection and storage, this can differ between various tests, so you should always refer to the specific procedures protocol. Now we'll get into the actual case study, which covers the youngest reported case of IgG4-Related Ophthalmic Disease. A 15-month-old boy was admitted to a hospital in Australia. He presented with a painless left eye proptosis, which is the bulging of the eye, and upper lid erythema over the past 2 weeks with no response to antibiotics. His visual acuity was examined with Cardiff cards, and in his right eye it was 619, and in the left it was 624. He had full ocular motility, and his systemic examination was unremarkable. IgG4-related disease can be associated with proptosis and inflammation, and the orbital disease is usually unilateral and can affect any part of the ocular adnexa, which would be the eyelid, orbital soft tissue, lacrimal gland, sclera, bone, etc. His medical history was significant for multiple infections. This included oral candidiasis, Staph aureus bacteremia, Klebsiella pneumonia urosepsis, and right hand abscess. The correlation between these and the disease in the patient is supportive of a certain gene deficiency that we're going to look at later on in the presentation. His MRI revealed left maxillary and ethmoid sinus enhancement. There is also a homogeneous mass in the left medial inferior orbit, which extended to the orbital apex. There is also rectus muscle enlargement. Figures A and B are showing the MRI of the brain and orbits with gadolinium, and these images show that enhancement of the left orbital soft tissue with the associated sinus and dural enhancement. In the histologic examination of the biopsy taken, it showed lymphoplasmacytic infiltrate, fibrosis, and focal obliterative phlebitis, all of which are classic features of IgG4-ROD. Figure A shows the dense lymphoplasmacytic infiltrate, and Figure B is showing the obliterative phlebitis, or vasculitis. In Figure B, the dashed line is indicating the vessel wall, and the asterisk indicates the lumen. And as you can see, the lymphoplasmacytic infiltrate is within the vessel wall. The immunohistochemistry showed greater than 100 IgG4 cells per high power field, and it showed he had an elevated IgG4 to plasma cell ratio. Now, if the ratio was greater than 40%, that would be a threshold for diagnosis. However, in this case, the quantification was limited due to background staining. Figure C, you can see that immunohistochemistry, and the red arrows are indicating the IgG4 cells. The immunohistochemistry is a major factor in diagnosis, but there does need to be correlation made with serologic testing, which we can see here in the blood test results with array serum IgG4 at 2.05 grams per liter, and also with the elevated ESR and CRP. There were other tests done, such as the full blood count and serology for autoimmune or infectious diseases, but these were all within normal limits. At this point in the case, the goal for the boy was immunosuppression. So they started him on prednisone at 1 milligram per kilogram a day and had it taper off at 3 weeks. They also started him on azathioprine and trimethoprim sulfamethoxazole prophylaxis. Later on, however, the boy was readmitted following multiple infectious episodes. This included Pseudomonas meningoencephalitis and cytomegalovirus viremia. Upon further testing of DNA and molecular testing, it revealed he had a homozygous variant of the IRAK4 gene, the IRAK4 gene. This gene deficiency is a novel finding of IgG4-RD. IRAK4 is a core component of the innate immune system, and it facilitates the signal transduction for toll-like and interleukin-1 receptor-mediated responses. The clinical presentation of this gene deficiency is marked by the recurrence of life-threatening infectious events, which include meningitis, abscesses, and sepsis, all of which were seen over the clinical course of this patient. It was also noted that elevated IgG4 levels have been reported in patients with IRAK4 deficiency, but the significance is not currently known. There's currently no universal treatment protocol, but the favored first-line therapy is that prednisone at 1 milligram per kilogram. A second-line therapy would be azathioprine, mycophenolate, methotrexate, or rituximab. Co-management with an immunologist and long-term follow-ups are highly recommended to monitor for relapses also. Here are the references I used for this presentation, and I hope you enjoyed this as much as I did. Thank you for watching.